We're blessed today to be joined by a true expert in the field of ACLs and really the revolution of what's going to happen from the Hospital for Special Surgery, Dr. Greg Difelice. Greg, thanks for joining me.
Hey, Robbie, how you doing today?
Good. All right, I can't wait to get into it. We did a promo this whole week about you coming on the radio, so let's get right into it. Let's talk about the ACL. It's the most commonly injured ligament in the athlete's knee. Surgery is the only real predictable way to restore the stability of this ligament getting blown out. What's the current state of the art with regard to fixing an ACL?
Well, you know what? The way we do it has been evolving over the course of the past 30 years. And essentially, if you think of the ACL like a rope that connects your shin bone to your thigh bone and stops your shin bone from going forward, what we do as surgeons is try and replace that with a new rope. Mm-hmm. So essentially, with the arthroscope, we'll sneak into your knee, we'll chop out all the torn up tissue from the old ACL, and then we'll go up to where the ACL used to start, and then where the ACL used to finish, and we'll drill a series of small tunnels in there. Mm-hmm. In the tunnels, we'll place some tissue, either from your body, most commonly the hamstring tendon or the patella tendon, or sometimes we'll use it from a cadaver source, from a dead person, mm-hmm. and we'll put that tissue up into those holes and then lock it in with either a series of screws or buttons. Mm-hmm. Your body really doesn't know what the heck's going on. It just knows that it's injured. So, as you know, the body attacks whatever graft that you put it in there. And in essence, and to keep it simple, essentially what happens is that we trick the body into making a new ligament out of scar tissue. Wow. The main trouble is that the human ACL is much more complex than just a tube of tissue running in one direction. It's more like 50 tubes of fibers that run in all different directions, and those end up stabilizing the knee throughout the range of motion. So it's a really complicated ligament that we end up putting in a rather simplistic solution for.
So you came up with a new way of not only fixing, but looking at the ACL and fixing the ACL. And you presented some early data about it. Tell us how you came up with this. Tell us all about it.
Well, you know, Robbie, my practice is a pretty trauma-heavy sports practice. So not only do I see athletes who get injured on the field, but I also see folks who get injured in industrial accidents and car crashes, mm-hmm. and a whole lot of much more severe injuries. So I tend to see a lot of people who have what's called multi-ligament knee injuries, where they'll have 3 or 4 ligaments out, mm-hmm. and that gets to be really complex surgery, trying to make 4 ligaments at once. Mm-hmm. And what I did early in my career, I've been in practice about 15 years, is when I saw one of the ligaments that was kind of torn off the wall, I would try and repair it rather than do all the drill the tunnels. Mm-hmm. And in my early experience, I noted that these things were working for me, and I was getting some stability from just stitching the ligament back to the wall.
And we were always told this can't work because the joint fluid prevents the scar from allowing the healing to take place. When the ligament that's torn is in the joint, like the ACL, it works for the medial collateral ligament under the skin, but we were always taught you can't. No, you can't do that. So tell us how you get around that.
So absolutely, that's exactly what we were taught. And as I got more and more experience doing this in these severely injured knees, what I started to see was I noticed that some of my patients who had ACL injuries had the ACL torn off the wall. And as I talked about before, if the ACL is a rope and it's ripped right in the middle, well, that's kind of hard to put back together. But if the ACL is a rope that's pulled off the wall, well, then you may have a fighting chance to actually stick it back to the wall. And I started to do that about 5 or 6 years ago in some very, very carefully selected patients by really borrowing the instruments from the shoulder sets where we do that on a regular basis in rotator cuff repair, mm-hmm. and bringing them down into the knee. Mm-hmm. I do a bunch of shoulder surgery, so I'm pretty facile with both joints. Mm-hmm. So if we took the stitchers from that we used in the shoulder and brought them down into the knee, and we put some stitches into the ACL, and then I started to use rotator cuff anchors in the knee to kind of pull the ACL back up to the wall.
It's fantastic.
Now, I will say that it's the only time you can do this is if you have the perfect tear. Mm-hmm.
By the way, just for translate,
nice results.
I just want to translate though. When you say you pull it off the wall, just for the listeners to understand, what you mean is it's not torn in the middle like you pointed out. What you mean is it's torn off the bone. The wall you're talking about is the wall of bone, and that's where the circulation is rich to the ligament itself. So you started to see some early results. Go ahead. I didn't mean to interrupt you.
No, that's great. So you and I both know, and we take it for granted, that you have to have blood supply in order to heal these things. And the bone is, as you mentioned, a rich supply of blood. So if we can, if the tear pattern is just right, we can put it back up against the bone, and then we have a fighting chance to have it heal. So as I got more and more success, I kept doing it and looking for more and more patients with this pattern of tear. And I'm up to about between 30 and 35 patients at this point.
Wow!
And I only have one early failure in a fellow who was rather non-compliant. Took his brace off the day after surgery and just kind of stomped around on it. But otherwise, we've got all the knees back to stable, and we were able to avoid doing the bigger reconstructive surgery.
Amazing. So the rehab time, was it quicker, different? Tell us what's going on when you primarily repair the ACL versus grafting it.
Well, what I've found is that in the right patients, the rehab time can be pretty impressively quick. Again, I don't want to give the wrong impression here that this is completely mainstay of treatment. This is early results of a new procedure. Right. But we've had good results. I've had a few people back playing full contact sports within 3 or 4 months, which is just shocking. Wow. Now, I didn't tell them to go back and play. They came back at 6 months and told me they went back to play. And they said their knee felt great, and they didn't even think about it. I
take care of a lot of stuntmen in this community in Hollywood, so I know what it's like when you tell someone to wear a brace and they come back going, I feel great, I don't wear my brace. Thank you. But
that one.
So you know exactly what's going on.
Absolutely.
So the disruption of the circulation, so when the ligament pulls itself right off the bone, do you think because you're using the ligament that's still attached to and let's just explain, most of the time it's ripped off the femur, not off the tibia.
Correct.
So you're saying that the circulation is still viable for 90% of it coming up through the tibia into the ligament. It's only disrupted way up high where it just pulled off of the femur, so it really only has to grow 3 or 4 months worth of blood vessels because the rest of them are already there.
Well, that's what we like to believe. It certainly seems that way in the cases the experience that I've had. I'm very, very particular about who I'll try it on because I don't want to really have any failures, so I'll only do it on the people with the perfect tears. And
you're blessed at the Hospital for Special Surgery. This is Dr. Gregory Difelice we're talking to, who's innovating just a real slap your hand, no, you can't do that, what we've been taught idea, and really changing the way. You're like reinforced concrete, Frank Lloyd Wright building the Guggenheim Museum, and everybody else is still using bricks and mortar. It's that kind of a change for us. I was just in New York this week, so I had to use that analogy.
Absolutely.
But that's really what is so inspiring about this story is that's where it has to come from. You literally have to be called crazy, and then it gets embraced. And we fight in orthopedics and sports medicine to double bundle it. Should you use a hamstring? Should you use a cadaver? How about using what you have? So my question is, are you getting help from the great Dr. Hollis Potter, the radiologist at Special Surgery? We don't have a Hollis Potter here in L.A. because I bet you she can start to tell you on the MRI the viability of the stump of the ligament. You know what I mean? That's sophistication of her eyes to be able to tell you, she's an amazing radiologist, of whether it makes sense to you. Do you get help from the radiologist, or is it just you looking at the MRI and then looking inside the joint when you do surgery?
Well, absolutely. We're very privileged here at Special Surgery to have a bunch of folks, including Hollis, who are tremendously trained and help us push the envelope. But really, the MRI, as you mentioned, is a tremendous tool that allows us to see the ligament and kind of ascertain the type of tear it is. So I can tell before I go into surgery if I'm going to have a fighting chance. Now, that I have to get in there and see what the tissue responds like in surgery to see if it will hold stitches and if it will actually work. But I can tell people beforehand, and I just saw one yesterday who we're going to operate on next week, that, look, you have this pattern of tear that may make it so that we can repair it. I think it's worth your while to try because we've had such good success in the very carefully selected patients. Not everybody has them, and right. What I will say is it's a specific type of twisting injury. It tends to cluster in skiers and snowboarders and that like, but I have seen it in all sports types. How
about women versus men? Are you just doing men?
No, I do it in both. If you look back at the old studies, I can't take credit for all of this because really, as you know, things tend to come full circle, to borrow your circle analogy.
That's right.
And people tried to repair the ACL way back in the beginning, way back in the early 1900s, and then it became very popular in the 70s. Mm-hmm. But what they did was they didn't have MRI and they didn't have all the amazing tools that we have in arthroscopy. So they would take the patient who felt a pop in their knee, they would cut the knee open like a total knee replacement, and they would try desperately to stitch the ligament back together and tie those little sutures up into the bones. And then they put the patient into a cast up to their hip for several months. And you and I both know that was probably the death knell for a lot of patients is immobilization.
Well, that's amazing.
And nowadays we have, incredible MRI imaging that can tell us which tears are likely to we can have a chance with. We've got incredible arthroscopic tools that we've advanced over the past 3 decades. And then we know so much more about the rehab to give these people a good chance of healing that we've really it's a whole new paradigm. So when I talk about it, I talk about going back to the future.
Exactly right. What a great term.
What they've did in the past. And after they analyzed all the results in the past, they said, this procedure is only about 50% successful. And they said 50% of the people are failing, so we need to stop doing this and start doing some other procedure. When in reality, what I think they should have done was they should have said 50% of the people are succeeding. Let's figure out how to fix the other 50%. Because I think they threw the baby out with the bathwater. That Mark Sherman wrote a paper, and he showed that the people with the proximal tears were the 50% who did well. So if you go back and analyze the old literature, it was all there, but it was buried in so much. The water was so murky and it was buried in so much other data because they were trying to repair mid-substance tears, and that pretty much doesn't work.
Greg, I want to thank you so much for joining us and teaching us here on the Weekend Warrior Show. When the results further come in, we're going to be calling you again. We really appreciate your insight, and we're rooting for you. So thanks so much for joining us today.
Thanks, Robbie. Have a good day.
Okay, you too. God bless you. That's the great Dr. Greg Difelice from the Hospital for Special Surgery.